The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, what happens when a patient denies they were informed about risks?
The practitioner who is going to perform the procedure is ultimately responsible for informing the patient and obtaining a valid consent.
That's Dr Tony Sara, Medical Advisor at South Eastern Sydney Local Health District, President of the Australian Salaried Medical Officers Federation and Fellow of the Australian Institute of Digital Health. And I'm presenting him with a difficult scenario.
They don't know what they don't know. They don't know the risks.
In this episode, Tony and I will discuss issues around informed consent. In this scenario, the medical administrator receives a letter from a very unhappy patient who was admitted acutely with kidney stones. They were given the option of waiting for the stone to pass or having surgery to remove it. The patient chose surgery. Unfortunately, their ureter was punctured during the procedure, resulting in the need for several subsequent interventions and a prolonged period with a ureteric stent. While the surgeon clearly documented the risks of puncture, the patient states they would never have consented to surgery if they had known what the consequences of such a complication were. Dr. Tony Sara starts by explaining to me what the key issues are in a scenario like this.
The key issues are informed consent and its documentation. Now, the issue about informed consent is a little bit nuanced. In the Rogers versus Whittaker case, the High Court made it clear that it was not the Bolam test, which is a responsible body of medical opinion, that the test became the reasonable patient and what the surgeon might have suspected would be of importance to that patient. So this has got all those sort of Rogers versus Whittaker tests built into it. So to answer the question very briefly, it's informed consent and what that means with the nuances about that, and also the documentation so that if an action commences, you've got some contemporaneous notes to say, this is what I told the patient and I mentioned these risks explicitly. And if the patient expresses any sort of hesitation, then you really, as the practitioner who's going to do the procedure, you have to drill down to the next layer.
So who's responsible for making sure that the patient has given their consent?
The fundamental legal principle is that the practitioner who is going to perform the procedure is ultimately responsible for informing the patient and obtaining a valid consent. So that's the proceduralist. In a private hospital, it is the proceduralist, him or herself. In a public hospital, this may be delegated to a DIT or a registrar, but the health department's policies around the country is the person undertaking this procedure is still responsible under case law for it, that the consent is valid, and that the DIT or the registrar has the skills, knowledge and experience to properly obtain informed consent. So the New South Wales Health Policy Directive now explicitly says if the DIT doesn't know what they don't know, then they should say, no, I don't get this, I don't understand it, I'm not in a position to get consent. Now, if it's an emergency laparotomy, then the DIT can get it. Sir or madam, you don't have this, you're going to die. But for elective procedures, young doctors are well advised to stay away from getting consent for risky elective procedures.
So DIT is a doctor in training.
Doctor in training.
Yeah. What about the anaesthetic? The anaesthetic's often as risky or as complex sometimes as surgery, particularly if the patient's older or sicker. Does the anaesthetist need to get consent as well?
It depends on the circumstances of the case. If the surgeon is comfortable that the risks of the anaesthetic are low compared to the risk for the surgery, then most surgeons' procedures would get that consent. If the person's got severe aortic incompetence or aortic stenosis and their blood pressure control during the procedure is going to be very risky, then it would be wise for the proceduralist to say, I'm not going to get consent for the anaesthetic, I will pass it off to the anaesthetist. So all the state consent forms around the country do not provide explicit consent for the anaesthetic because in most cases the risks are low. So it would be up to the surgeon to form a judgment. The risks of this anaesthetic are so high, I'm not enough of an expert. If something goes wrong and the anaesthetic is the cause of death, then I want the anaesthetist to be getting their own consent. So again, it comes down to the details of the case. Most times it's not required to get a separate consent for anaesthesia. If it's very high risk, then the surgeon will be well advised to get the anaesthetist to get their own consent.
Very often the consent's signed in the doctor's rooms, either in the outpatient or in the case of private, in their private rooms. Does the hospital have an obligation to make sure that the consent is valid, or can they just take the piece of paper as supplied?
Given that the medico legal responsibility accrues to the surgeon, then my view, I'm not a lawyer, but my view is that the hospital has discharged its responsibility by accepting the piece of paper on face value, that most of the states now have a section to be filled out by the proceduralist and another section to be filled out by the patient. So if they see a form come from the doctor's rooms and it looks like the doctor's normal signature and there's some sort of words saying what the procedure is, then my sense is that hospitals are entitled to rely on the piece of paper signed by what looks like the surgeon, signed by the patient. All hospitals in Australia have a process pre-surgery to check there is a consent form. If there's no consent form, the operation ceases unless it's essential to save the person's life at that instant in time. But all hospitals have got a process to check that there is a form, and my sense is that the hospital can rely on the form.
So when can consent be implied? What's the sort of threshold? The person comes and says, I want you to take this mole off my arm. The GP or the proceduralist doesn't usually sign a consent. On the other hand, if you're having major surgery, consent's absolutely required. So what's the sort of threshold between the sort of implied consent and formal informed consent?
Well, implied consent means that the person's behaviour suggests they're agreeing. So you want to take their blood pressure, they hold their arm out. You say, I want to take some blood, they hold their arm out. They've got a skin cancer that needs removal, and the GP will say that needs removal, and they say, how are you going to do that? Bit of local, I'm going to cut it out. There'll be an elliptic shape, 2 centimetres long, and they hold their arm out. So the risks of the surgery going wrong are really low. They're not entering body cavities. They're not doing anything that's likely to result in harm immediately. So implied consent means that the person's actions support the fact that they're agreeing to what you're proposing. In terms of written consent, as I understand the health department's views around the country and the case law, it can be oral, but the cases that have occurred have generally had a feature of them presenting the consent form to the court. Your Honour, I discussed this with this patient. This is the form that I used. So it means that it is much less likely that the patient can claim, I was not really told, there was no process to inform me. So doing a written consent form for anything that's got any material risks attached is in the doctor's and hospital interests to prevent a claim from the patient during litigation, you didn't tell me anything. So it's a contemporaneous note at a point in time, Your Honour, there's the piece of paper, I did this. And so the patient is much less likely able to deny the fact that a conversation took place.
What about the other scenario where the patient's done all of their research, they've consulted Dr. Google, and they come to the surgeon saying, I want you to do this procedure? What's the role of consent when the patient's asking for a procedure?
As I understand the case law, it is still up to the proceduralist to gain informed consent. The person is asking for something, unless they're a surgeon experienced in that particular field of surgery, they don't know what they don't know. They don't know the risks, they don't know the complication rate for that surgery, and as I understand the lawyers and the case law, even if someone asks for something, it is in your interest as a surgeon and your interest as a hospital to say to the surgeon, you will get this consent, as a way of reducing medico-legal liability if something goes wrong. And as we all know, surgery does go wrong from time to time. So the patient requesting it in one sense is irrelevant. because the patient cannot be an expert in that field, and therefore the expert has to give them all the information, the risks as to benefits, risks, material risks, blah, 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 blah. So therefore written consent is still required.
It's a real fraught issue because it's easy as a doctor to assume that if the patient asks for the procedure, they know what the complications are. But you're right, they're not an expert.
They're not an expert.
Yeah.
If they're a surgeon in that particular field and they said to the surgeon, look, I understand these are the risks, these are things, this is the complication, blah, blah, blah. But the chances of that are really low. And given that bad things often happen to doctors who are patients, I'd be saying to any surgeon that's doing this, it doesn't matter who it is, you need to prevent liability as much as possible for yourself and for the hospital. You will get written consent.
What does the doctor need to document?
They need to document the fact that they had a conversation, and the conversation revolves around three main things: genuine understanding of the nature, the effects, and the material risks of the proposed procedure. Now, material risks is a really important concept, and I'll read what the High Court said about this. A risk is material if a reasonable person in the patient's position, if warned of the risk, will be likely to attach significance to it, or if the doctor is or should reasonably be aware that that particular patient, if warned of the risk, will be likely to attach significance to it. So in this particular case of the removing a renal stone or a ureteric stone, if this patient was really anxious about the whole deal, then the surgeon should have drilled down to the next layer and said, not only there's a risk of puncturing the ureter, if we puncture the ureter, then you will need a stent for the next 2 to 3 months. You will have these multiple trips into the hospital. It comes down to the risks of the material, and it's not in the minds of the doctor, it's in the mind of the patient, as the High Court said. So a reasonable person in the patient's position warned the risk will be likely to attach significance to it, or if the doctor is or should reasonably be aware that this particular patient, if warned of the risk, will be likely to attach significance to it. So in this particular case, the doctor should have gone the next layer down and worked out whether this patient was prepared to tolerate that risk, a material risk of a puncture of the ureter.
It's a really difficult decision to make in a case like this. Ureteric stones are incredibly painful. And the patient says, well, do anything you can to stop the pain. I don't care.
Yep.
10 days later, when they've got a stent in and it's uncomfortable and they're lining up for 2 or 3 additional surgical cases, they look back and say, I was silly to give consent. I didn't realise what was involved. How can you balance that foresight versus regret?
It's really difficult. And so it does come down to a deep experience of proceduralists dealing with patients and getting a sense for that particular patient, and that's what the High Court said, that particular patient, if they would attach significance to it. So in this case, if the surgeon said, the risks of ureteric puncture are 5%, 10%, and if the patient's body language changes at all, then the surgeon would use their judgment and say, do you know what that means? You would ask what it means, and you would give them that extra information. And then the patient has been made fully aware of the material risks. And if the patient still says, look, the pain is so bad and I'm sick to death of oxycodone and non-steroidal anti-inflammatories and I can't get on with my life and blah, 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 I'm prepared to take that risk, then the patient has been fully informed of the material risks. And if they say yes on that basis, then the surgeon would write risks of ureteric puncture advised and sequelae. Patient still agrees, then if it went to litigation, the doctor's notes, as we said at the very beginning, it's informed consent as documentation, that the surgeon will be able to say, look, the patient asked about this, I told them what the risks were, I told them what the sequelae were, and if they've got notes to say that, then the litigation falls away.
Thanks, Tony. What about gaining consent to risky interventions? Novel techniques, things that are experimental, and the surgeon can't be positive about the risks or the outcomes.
I think it's just a repeat of what we've just said. The material risks are much higher. The surgeon would need to make it very clear to the patient that this was novel, that this was experimental. Of course, in both public and private hospitals in Australia, you can't do novel or experimental work without going through a new technology assessment process. So you would need to make sure that the person was fully informed, and you might even sort of start talking about, the risks of dying, of not having this procedure are 10% over the next year, and the risks of living if this procedure works is X percent. The surgeon will be well advised to be as explicit as they possibly could and to get the person to agree on the basis of those. It comes back to material risks. And so in those cases, procedures would be advised to go into it in enormous depth of detail and to document the conversation in detail.
The other scenario that's very tricky is the emergency situation, where the patient may be unconscious and unable to give consent, but their life's at risk. So what are the issues with consent when consent can be hard to obtain?
As I understand the law and the case law, if you can't get consent and you believe that something is necessary to save their life or limb, the attending doctors are entitled to make those decisions and provide that life-saving surgery. They should try and get substitute decision-making consent. They should check with the family under the various guardianship acts in various states and territories. There is a hierarchy of decision-makers. If you can't get a decision-maker and the person's got a couple of feet of infarcted small bowel, and if you don't cut it out in the next 2 to 3 to 4 hours, they're going to die, then surgeons are entitled to make those decisions to save the person's life, even without any consent.
The other side of that's the use of interpreters.
Oh, yes. Interpreters is a really difficult area. All the health departments have got policies around this, and that is that in all cases, whenever you possibly can, you should use accredited and authorised interpreters. You should document the use of that interpreter. State governments provide interpreter services. The Commonwealth provides telephone interpreter services. You should document the fact that you have used that interpreter, either the booking session or the employee ID, their name, that they participated. As a general rule, you should try and have them in the room with you. Obviously, if it's a rare language and it's 2 o'clock in the morning and all you can get is the Commonwealth Interpreting Service, then you would do what you can. But again, 2 o'clock in the morning, it's more likely to be an urgent or emergency surgery that's required. But for elective procedures, practitioners are strongly advised to use accredited interpreting services. In rare circumstances, if you can't get an accredited interpreter, you might use family members. But using family members is fraught with difficulties. Family members don't necessarily translate directly. They try and shield the feelings of their relative. They don't necessarily use the correct words. They mangle the interpretation. So bottom line, in all possible cases, use an accredited interpreter service and document that you've used one. There's been a few cases over the last few years in New South Wales where the use of interpreter services has been a factor in it. And when the patient claims, I didn't understand what he was saying, if you haven't used an interpreter, you've got nowhere to go. You are unable to get informed consent unless the person can understand what you're saying and you can understand them. So it becomes one of those, you must have this to get informed consent. Now, obviously, if you are fluent in the patient's language, you can get away with it. But even then, you would be wise to get the independent expert, document that they participated, even if you're fluent in that language.
What about using a nurse from the ward who speaks the language?
That's second tier. You need an independent authorised person because there are schemes to accredit interpreters. So again, that becomes the second tier. If you can't get the accredited interpreter and it's 2 o'clock in the morning and you need to do something to that person, then using a nurse is better than having no one. And it would be better than having a relative too, of course.
What about the issue of age? What age does a person have to be before they can give informed consent?
That's a little bit dependent on the legislation in states and territories. It's around 16 in most states and territories. In New South Wales, it can be between 14 and 16 because it's 2 acts of the Parliament that refer. But there's been a House of Lords case called the Gillick case, which was confirmed in Australia by the High Court in Marion's case. And the concept is of mature minor. A mature minor is able to give consent. And the words from Marion's case in the High Court are, a minor is capable of independently consenting to or refusing the medical treatment when they achieve a sufficient level of understanding and intelligence to enable them to understand fully what is proposed. So that means there is no set age, but given that the age for competence is around 10 or 12, practitioners would be very unwise to use the Gillick test on someone less than 10 or 11 or 12. It's too grey a zone. It would also come down to what's being proposed. If you're at Kirkton Road, which runs clinics for street kids, and a 14-year-old comes in and says, I'm doing risky sexual activity, I want the oral contraceptive pill, it would be reasonable to apply the Gillick test in that case. To say this person is a street kid, they've got sufficient maturity and understanding and intelligence to understand what's proposed, the risk of the oral contraceptive pill are low. If they came in with some broken bones in their fingers, then again, they're able to give consent in the emergency department to the repair of those fingers. If they needed some K-wires, you'd probably say, if you can't find a guardian or a parent, you'd probably say, look, the risks are low. But if they had an intra-abdominal mass or they had something that required surgery that was much more risky, then I would say to the practitioner, it would be unwise to use the Gillick competence test on a 14-year-old. If this goes wrong, then, and the person dies, the court of public opinion, the front page of the Daily Telegraph, and the parents who eventually can be found will say, I didn't give my consent to this and my child has died. So Gillick competence, I think, is in that middle zone of procedures that are not particularly risky. It's not worth the effort to substitute consent from a parent or guardian. But for high-risk procedures, I think it would be unwise for a hospital or a surgeon to rely on the Gillick competence test for very risky procedures. It doesn't pass the test of the front page of the paper.
Thanks, Tony. The scenario around contraception also raises a range of issues around confidentiality, child protection, and a doctor's mandatory requirement to report child abuse. These are complex topics, so perhaps we can explore these issues in another podcast. Tony, I'd be interested in exploring the flip side of informed consent, and that's informed directives, where the patient explicitly said, I don't want this to happen to me. And it's written and documented. Can a doctor's judgment as to what's best for the patient override an instruction from a patient not to have that intervention?
As a general rule, the answer is no. It cannot override it. However, the experience in emergency departments around this country and around the world is that large numbers of these advanced care directives are internally contradictory. They don't necessarily envisage all circumstances that may arise, and practitioners are advised by their employers and by their health departments to look very carefully at the advanced care directive and make sure that it is valid. In other words, it was made by a person who had competence, that is specific to a particular set of circumstances, and lastly, that the circumstances that are outlined in the directive apply at this instant in time. So, the Hunter New England case was tube feeding, and the advanced care directive was, if I become unable to cope completely, I don't want artificial feeding. So the Supreme Court said, fine. So to summarise, it was made by a person who was competent. It is specific enough that you can understand what it means. And thirdly, that the specific circumstances outlined in the advanced care directive apply at this point in time. So if you're not sure, most health departments and employers say, keep going, save the person's life, until it can be resolved by the patient or their family, or unfortunately it sometimes goes to the Supreme Court to be the arbiter in those circumstances. So the answer, to summarise, the answer is yes, an ACD can prevent something happening, but the reality is that it's not always clear exactly what the ACD is saying, whether it applies at this point in time. And so the instructions to emergency doctors are, if you are not sure what it means, then you keep going and you seek legal advice.
Thanks, Tony. One of the challenges is surgeons often overestimate their skills, and they will say the complication rate for this procedure is 2%. But you know that in the hands of this particular surgeon, the complication rate's much more like 5%. How do you reconcile the patient giving consent on a statistical basis that's not reflected in the complication rate for a particular surgeon?
The difficulty there, I guess, is that the role of the surgeon is partly separate from the role of the hospital. So if the surgeon says, my complication rate is 2% and it's actually 10%, the hospital is not really in a position to be a party to that process, because it isn't a party. It's not a party to the process. It's a process between the surgeon and the patient. Given that the College of Surgeons now requires, and the Medical Board of Australia now require reflective practice, if the surgeon knew that their complication rate was 10% and that of their colleagues was 5%, and they knew that in advance, which they should know, then the consent that they obtain would be invalid. Now, the patient is going to have to run the action for damages in the Supreme Court, not the hospital. So even though the hospital may know that, what the complication rate is, unless they insert themselves into the consent process, they're not in a position to say to the surgeon or to the patient, he's wrong. So it comes back to the professionalism of the surgeon, and I don't believe the hospital has a role in that. Now, if, of course, the hospital, as part of its clinical governance processes, works out that this surgeon's got a complication rate of 20% and everyone else has got a complication of 5%, then the clinical governance processes for that hospital and the Department of Surgery should have picked that up after a few years. complication rates for surgeons are generally known, roughly. So you would hope that the hospital would pick that up, and that if the surgeon's rate of complications is truly 4 times their colleagues and their peers, then the hospital needs to start doing something about it. It needs to talk to the head of the Department of Surgery, it needs to talk to the surgeon, needs to work out what's happening, why. Is it case selection? Is this person doing cases that no one else will do, in which case then the complication will go up? I mean, as you're aware, the death rate from ruptured AAAs is 50%. And if you're a surgeon with a death rate of 40%, you'll say they're better. But a complication rate of 60% is not beyond the realms of possibility, because they're doing ones that no one else will touch. So it comes back to those governance processes in the Department of Surgery to track the complication rates. And if they get too high, then the hospital has an obligation, and that was the obiter dicta in Boland versus Royal Prince Alfred Hospital. The vicarious liability for surgeons came into train in that case all those years ago, and I think the case law of the Commonwealth is fairly clear across Australia now. The hospital has a non-delegable duty of care to ensure that the surgeons it's appointing and it is supervising are up to scratch, that they do not have untoward complication rates. And if something happened and the patient sued the hospital would probably lose. But as medical managers, our job is to make sure that those governance processes are there and complication rates that are inordinate are noticed, tracked, action is taken.
Thank you, Tony. Very sentinel observation on safeguarding healthcare and the responsibilities of the medical manager. Thank you very much for your time, Tony.
Pleased to help. Thank you, David.
That was Tony Sara speaking about informed consent. That brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.